The world is still half asleep when my day begins. At 5:30 a.m., Memphis is quiet, the streets washed in the pale orange glow of streetlights. But inside the Liban Children's Hospital, another kind of day is already well underway. I push through. The front doors, the familiar scent of antiseptic and warm coffee greeting me like an old friend. My footsteps carry me toward the heart of the building, the neonatal intensive care unit, a place where every second matters and every heartbeat is precious. The NICU is not like the rest of the hospital. It's its own small universe. Rows of incubators hum softly, casting a warm, artificial glow over impossibly tiny figures swaddled in blankets. The air is alive with the rhythmic beeping of monitors, the gentle hiss of oxygen lines, and the occasional soft cry that can pierce even the most battle-hardened heart. This is where I've spent the last 22 years of my life, not just as a doctor, but as a witness to the rawest edge of human existence. I'm a neonatologist, a pediatrician who works exclusively with newborns, especially those born too soon, too small, or too fragile to survive without help. And here, in this room, I've seen things that could make you believe in miracles, and others that could break you into pieces. I've watched babies born at just 24 weeks, no bigger than my hand, skin so translucent you could trace every vein, grow into healthy, laughing children who run back into this ward years later to show us they made it. I've seen twins born so tiny they fit together in the curve of their father's palm, only to leave months later in matching car seats, their parents' eyes shining with exhausted joy. I've watched newborns undergo open-heart surgery days, after their first breath, and years later, seen them finish marathons. But I've also been there for the moments that leave scars you can't see. I've stood with parents as they held their baby for the first and last time. I've walked families through months of struggle, only to watch complications take their child away in the end. The weight of that, the knowledge that you are, standing between life and death for the most vulnerable patients in the hospital, never leaves you. After more than 2 decades, I thought I understood every side of this work. I thought I'd learned to carry the joy and the grief, to honor the wins and mourn the losses, and then keep going. But 2 months ago, I stumbled into something that upended everything I thought I knew. Not just about medicine, but about my own city's history. It wasn't about the usual NICU miracles or tragedies. It wasn't even about something that happened in my career. It was older, buried deep in the past, a past that, as I would discover, still casts a long shadow. And once I saw the truth, I couldn't unsee it. What I found made me question the very profession I've dedicated my life to. Because there was a time, not all that long ago, when people wearing white coats and carrying stethoscopes didn't just fail to protect the families who trusted them. They became the very threat those families needed protection from. The email came on a gray November afternoon, tucked between appointment reminders and lab updates. It was from Dr. Evelyn Carrington, conference coordinator for the American Academy of Pediatrics annual meeting, the kind of event where the air hums with ambition and people still wear their credentials like armor. Her message was short, but weighty. Dr. Keaton, we would be honored if you would present at our Historical Medicine Symposium. Topic: Evolution of Neonatal Care in the American South, Historical Perspectives and Modern Advances. I read it twice, just to make sure I hadn't imagined it. This wasn't the kind of invitation you turn down. The Historical Medicine Symposium was the jewel in the Academy's crown, a place where leading pediatricians, historians, and scholars gathered to exchange not just data, but legacies. For most people, it was a once-in-a-career opportunity. For me, it felt like a calling. I knew the task ahead would be enormous. This wasn't a walk-in with a slideshow and wing-it kind of talk. The research alone would take months, poring over dusty archives, combing through medical journals yellowed with age, and diving headfirst into a century's worth of data most people would find coma-inducing. But I've always believed history matters, especially in medicine. The past isn't just numbers and old photographs. It's the foundation we build our practice on. Memphis seemed like the perfect case study. My city has been a major medical hub for over 100 years. Our hospitals, Methodist, Baptist, St. Joseph, had reputations that stretched far beyond Tennessee. We had teaching programs, cutting-edge techniques for their time, and detailed records dating back to the 1920s. I imagined telling a story that traced our progress from the early 1900s to today, a story of innovation, resilience, and the tireless fight to keep the tiniest patients alive. I began the work like any disciplined researcher. I reached out to the University of Tennessee Health Science Center, the Memphis Medical Society, and the dusty but reliable hospital archives. I asked for everything: infant mortality rates, birth statistics, hospital protocols, training methods, causes of death, breakthroughs, failures. If it involved newborns, I wanted it. The early findings were exactly what I expected: a steady march toward better outcomes. The 1940s brought antibiotics, cutting infection deaths dramatically. Improved nutrition meant fewer malnourished mothers and healthier, heavier babies. Surgical techniques evolved, and suddenly babies born with heart defects or gastrointestinal malformations had a fighting chance. I filled my office with colorful charts and graphs that told a hopeful, upward story: fewer deaths, longer lives, healthier starts. It was exactly the kind of inspiring narrative the conference was built for. Until I saw the numbers that didn't fit. I was double-checking my data against records from the CDC and the Tennessee Department of Health when I saw it: a glaring spike in infant mortality rates in Memphis during the 1930s and 1940s. Not just high, the highest in the nation for several years running. At first, I thought I'd made a mistake. Maybe I'd mismatched the data sets or pulled numbers from the wrong column. But no, it was all there, in black and white. In 1935, Memphis recorded 94 infant deaths for every 1,000 live births. The national average that year, 55. Cities like Boston and San Francisco hovered in the low 40s. Even rural farming regions, with their limited hospitals and poverty, rarely hit numbers above 70. Memphis wasn't supposed to be on that list. We had resources, trained physicians, clean water, stable infrastructure. The Great Depression had hit us like it had everywhere else, but our economy, bolstered by river trade and rail, was stronger than most. By all logic, our numbers should have been on par with Atlanta, Birmingham, or Nashville. Instead, they were off the charts, and the strangest part, the deaths weren't evenly spread. They clustered: certain hospitals, certain months, sudden spikes that vanished as quickly as they appeared. I stared at those spreadsheets late into the night, my coffee growing cold beside me. The patterns didn't make sense medically. No known outbreaks, no environmental disaster, no scandal in the papers, just a city with some of the best medical facilities in the South, and numbers that screamed something was terribly wrong. At the time, I didn't know it yet. But those numbers weren't statistics. They were smoke, and I was about to find the fire. As a neonatologist, I've spent my life decoding the puzzle of infant survival. I know the patterns. High infant mortality usually has a clear culprit: poor prenatal care, malnourished mothers, lack of access to hospitals, or infectious outbreaks that spread like wildfire. In rural communities, it's often a mix of all these factors. But Memphis in the 1930s and 40s? We didn't fit that profile. We had skilled physicians. We had multiple hospitals with modern facilities for the time. Our infrastructure, clean, water, electricity, sanitation, was far ahead of many southern cities. Whatever was happening in Memphis, it wasn't neglect, poverty, or disease alone. And yet, the data didn't lie. I laid out the mortality charts across my desk, each year's line climbing and falling like some kind of coded message I couldn't yet decipher. But one detail jumped out immediately. The spikes weren't random. A 3-month surge here, 4 months there. Sharp increases at specific hospitals, while others stayed near normal. Then, just as abruptly, the numbers would settle again, as if someone had flipped a switch. If this had been tuberculosis, I would have seen corresponding adult cases and lung disease reports. If it were tainted water, every age group would have suffered, and the public health department would have sounded alarms. If it were incompetence, faulty equipment, poor training, there would have been lawsuits, disciplinary hearings, whispers in the papers. There was nothing. No headlines, no official investigations, no signs that anyone in authority had even noticed. That's when I drilled down into the cause of death records. What I found made the hairs on the back of my Neck stand up. Again and again, I saw the same vague phrases. Constitutional weakness. Inability to sustain life. Complications following birth. Not precise medical terms. Just empty placeholders that said nothing and explained less. Even stranger, the same names kept appearing on the death certificates. Dr. Vernon Hawley, over. 200 infant deaths between 1935 and 1940. Dr. Martin Alden, nearly 150. Dr. Lawrence Whitaker, more than 180. To put that in perspective, in my 22 years in one of the busiest NICUs in Tennessee, I've signed fewer than 50 death certificates. Modern medicine saves more lives now, yes, but even accounting for advances, the volume these men recorded was staggering. And these weren't tragic preemies with low birth weights and long odds. Many of the infants listed as premature were actually born full-term with healthy birth weights. Some were marked as having congenital defects despite perfect APGAR scores. Others were said to have died suddenly without a single documented risk factor. That should have triggered investigations, autopsies, follow-ups, public health alerts. But in case after case, I found nothing. No autopsy reports, no burial records. In some instances, it was as though the child had simply vanished after being declared dead. Vanished. I sat there in my office one December night, the building quiet, except for the hum of the vending machine down the hall, staring at the cold glow of my computer screen. This wasn't bad luck. This wasn't medical failure. Something else was happening here. The question was, what? That's when I decided the answer wasn't going to be found in the medical records alone. If the numbers didn't make sense in a clinical context, maybe the context wasn't clinical at all. So I widened the scope. I began looking into the broader history of Memphis during that time period. Politics, social movements, notable figures. I wanted to know who had influence in the city, who had power over hospitals, and who might have benefited from keeping these deaths quiet. That's when her name appeared. Georgia Tann. And with it, a trail that would pull me into one of the darkest chapters in American medical history. On paper, she was a civic treasure, founder of the Tennessee Children's Home Society. A woman who, according to the newspapers of the time, devoted her life to rescuing orphan children and placing them in loving homes. The photos I found showed a neatly dressed, smiling woman with soft curls and a calm, matronly demeanor, the kind of face that inspired trust. Articles described her as a pioneer in child welfare, an advocate for adoption reform, and a personal advisor to influential politicians. Eleanor Roosevelt herself had reportedly consulted her on children's policy. If you had asked the average Memphian in the 1930s what they thought of Georgia Tann, they'd probably have used words like kind-hearted, selfless, maybe even heroic. But the first red flag for me wasn't in her personality. It was in her numbers. According to records from 1924 to 1950, the Tennessee Children's Home Society facilitated more than 5,000 adoptions. That's roughly 200 a year. Even modern, well-staffed agencies rarely manage that volume. And yet, this society operated with fewer than a dozen employees. Then came the geography problem. While the children came mostly from Tennessee, Arkansas, and Mississippi, the vast majority of adoptive families lived thousands of miles away. New York, California, and other states with very different adoption laws. Normally, agencies try to place children locally to preserve cultural and familial ties. But Tann's operation shipped them cross-country like freight. And then, the secrecy. Legitimate adoption agencies keep meticulous records, medical histories, family backgrounds, placement details, so that if a child needs emergency care or seeks their roots later in life, there's a trail to follow. Georgia Tann's agency destroyed or falsified most of its files, claiming it was to protect privacy. In reality, it made verification impossible. There were whispers, though, subtle, scattered mentions that didn't make the front page. A 1941 Child Welfare League report questioning the society's practices. A 1946 Memphis probate judge's letter warning about children removed from families without due process. A 1949 editorial asking why so many Tennessee children were adopted out of state. But every time concerns surfaced, it disappeared just as quickly. The reason became clear. Georgia Tann had friends in high places, most notably Edward Boss Crump, the political kingmaker who controlled Memphis for decades. Investigators were pressured, critics were silenced. Courtrooms, including those of Judge Camille Kelly, seemed to bend in her favor. It wasn't until I found the 1950 report by Tennessee Attorney General Robert Taylor that the full horror began to emerge. Taylor's investigation didn't paint Tan as a misunderstood reformer. It described her as the head of a criminal enterprise, one that systematically stole children and sold them to wealthy adoptive parents for enormous profit. And here's the part that made my pulse spike. One of her primary pipelines for acquiring these children was Memphis hospitals. She wasn't waiting for orphans. She was manufacturing them. The scheme was brutally simple and devastatingly effective. Georgia Tan had cultivated relationships with nurses, doctors, and hospital administrators across Memphis. She didn't need to break into homes or snatch children from parks, though she sometimes did that too. Her preferred hunting ground was the maternity ward. When an unmarried woman or a poor family gave birth, the hospital staff in her circle knew what to do. The newborn would be whisked away under the guise of special care or an emergency transfer to another facility. The mother, often sedated during delivery, as was common practice, would be told hours or days later that her baby had died. A death certificate would be issued, signed by one of Tan's trusted physicians, listing a vague cause like complications following birth or constitutional weakness. The grieving family would be sent home empty-handed, never knowing the truth. Their child was alive, hidden in Tan's custody, awaiting sale to an adoptive family willing to pay today's equivalent of $50,000, $70,000. Suddenly, the anomalies in my mortality data made sense. The clustered deaths around certain hospitals, those were Tan's strongholds. The spikes that lasted just a few months, those were periods when she was actively filling orders from adoptive parents. The vague, nonspecific causes of death, cover stories written by doctors who never examined a body. But the nightmare didn't end there. If a child wasn't placed quickly, they were kept in the Tennessee Children's Home Society's facility on Poplar Avenue. The conditions there, according to Attorney General Robert Taylor's 1950 report and survivor testimony, were appalling. Dozens of children crammed into small rooms. Minimal medical care, filthy bathrooms, poor sanitation, malnutrition so severe that some children's growth was permanently stunted, sedatives used to keep babies quiet. Sick children were often left untreated. Those who cried too much or caused trouble were physically abused. Many simply didn't survive. Taylor's investigation estimated as many as 500 children died from neglect, disease, and abuse in Tan's custody. And yet, she kept the public image of a savior. It wasn't until survivors began speaking out decades later that the full human toll became visible. I read their stories late into the night, each one more gut-wrenching than the last. There was Alma Sipple, whose toddler daughter Irma developed a cough in 1946. Tan promised free medical care at a better hospital. Days later, Alma was told her child had died of pneumonia and was already buried. 43 years later, Alma learned the truth on national television. Irma had been alive all along, adopted out and raised under another name. Their reunion came only in 1989. There was Devo Debbie Devi, who grew up believing she was an orphan, only to discover in her 70s that she had been stolen as a baby and that she had a biological sister living just hours away. They met for the first time in 2009, both elderly women, robbed of decades together, and perhaps most haunting of all, Sandra Lee Bridgewater, renamed Cindy Lou Presto, kidnapped at age 2 while playing in a park. Her mother, Evelyn, never stopped searching. But forged court papers and a complicit judge erased her parental rights in a matter of hours. 32 years later, Sandra learned she had been living a lie. Her adoption, the result of a criminal conspiracy. These weren't isolated tragedies. They were pieces of a system that thrived on the cooperation of people who had sworn an oath to protect life. Every false death certificate bore a doctor's name. Every stolen baby passed through a nurse's hands. And that was the part that kept me awake at night. The knowledge that my own profession had once been a willing accomplice in a trade of flesh and futures. By 1950, Georgia Tan had trafficked over 5,000 children in a 26-year career, generating profits worth more than $10 million today. She died of cancer just days before Governor Gordon Browning's investigation became public, escaping justice. Most of her enablers, and including those in white coats, never faced consequences. The more I read, the heavier the weight on my chest became. These weren't just historical crimes. They were violations of trust so profound that they still ripple through families generations later. And I knew, as a doctor, as a Memphian, and as a human being, I couldn't let this be forgotten. The first thing I felt was anger. Not the hot, fleeting kind, but the deep, slow-burning rage that comes when you realize people who wore your same white coat once turned it into a disguise for evil. Medicine is built on trust. Every day, parents hand us their newborns, their whole world wrapped in a blanket, and believe we will protect them. That trust is sacred. The doctors and nurses who worked with Georgia Tann didn't just break it. They weaponized it. In my 2 decades in the NICU, I've carried the grief of losing patients. But those losses were honest battles with biology, not betrayals by human hands. What happened in Memphis between 1924 and 1950 wasn't medicine. It was organized theft. I couldn't let it fade into the dusty corners of history. I began speaking to medical schools, pushing to include the Georgia Tann case in ethics curricula. Students needed to understand that medical harm doesn't always come from negligence. Sometimes it's deliberate, hidden under the language of care. I reached out to genealogists and historical societies, offering my help in reviewing old hospital and death records. Every false certificate I uncovered felt like a chance, however slim, to restore a piece of someone's stolen history. And I tell anyone who suspects a family connection to take a DNA test. Modern genetic databases can do what decades of secrecy tried to prevent: reunite bloodlines. The children Georgia Tann stole are now in their 70s and 80s. Time is running out. But every match, every confirmation, every reunion pushes back against the silence she left behind. Some days it feels overwhelming, like trying to stitch together a quilt that was shredded 70 years ago. Most of the records are gone, destroyed, intentionally. Many birth parents have passed away, never knowing the truth. But even when reunions aren't possible, the truth itself still matters, because truth reclaims dignity. Truth says, you were wanted, you were loved, you were stolen, not abandoned. I've walked into rooms to tell parents their child didn't make it. I've felt the way grief collapses a person from the inside. Imagining that pain inflicted by design, multiplied by thousands, is almost unbearable. And yet, as a city, we lived with it. We buried it. But history buried is history repeated. That's why I tell this story, even when it makes people shift uncomfortably in their seats. I tell it because medicine is not immune to corruption, and the only safeguard we have is relentless accountability. Georgia Tann may have believed she could erase identities, bury evidence, and rewrite family histories to suit her profits. But she couldn't touch DNA. She couldn't erase the human need to know where we come from. And that's why I keep digging. For the children who vanished from birth records, for the families left with nothing but a false cause of death, for the truth that still waits, quiet but unbroken, in the bloodlines of my city. One day, perhaps, we'll have all the names. Perhaps all the stolen will be found. Until then, I'll keep telling their story, not just as a doctor, but as a witness. Because the NICU teaches you 2 things. Life is fragile, and every heartbeat counts. And history has taught me this. So does every truth.